Congestive heart failure, or CHF, is a very common medical condition in the United States. Currently, it affects over 2 million Americans, and over 400,000 new cases are diagnosed each year. Due to the increasing age of our population, the number of patients with heart failure is increasing every year. In the past, before we truly understood CHF and had effective preventive therapy, the average length of life from the time CHF was initially discovered was only 5 years. Great advances have occurred in just the last few years for the treatment of CHF. In this video, you will learn how CHF works, what causes it, and most importantly, what we can do together to improve the length and quality of your life. There are two types of CHF. One type of CHF is from having a weak heart muscle. The second type of CHF is from having a heart muscle that is too stiff. The ejection fraction is the percentage of blood pumped out of the heart each time it squeezes. A normal ejection fraction is anywhere from 55 to 75%. If the heart muscle is weak, the percentage of blood that will be pumped out, or the ejection fraction, will be less than normal. This is a weakened heart in which only 10 to 15% of the blood is pumped out of the heart. If the heart is weak, the amount of blood pumped out each time the heart squeezes is less than normal. Hence, the ability of the heart to pump blood and oxygen to the muscles and other organs of the body is reduced. This produces weakness, a reduction in your ability to exercise, kidney failure, fluid retention, especially leg swelling, loss of appetite, and when severe enough, mental confusion. When the heart is stiff, very high pressures are required to fill the heart with blood, and this pressure backs up into the lungs. This high pressure in the lungs causes fluid to accumulate in the lungs, producing shortness of breath with exertion, shortness of breath when lying flat, and can cause shortness of breath at night, causing a person to wake up from sleep. If this lung pressure is high enough, fluid will even accumulate in the stomach area and cause swelling. The causes of congestive heart failure are no longer a mystery. As a matter of fact, the 11 causes of CHF are very specific. They are cholesterol blockages in the arteries feeding the heart, or atherosclerosis, high blood pressure, bad heart valves, alcohol, cigarettes, diabetes, problems with the thyroid gland, iron storage disease, anemia, thiamine deficiency, and infections. Far and away, however, the most common causes of CHF in America is atherosclerosis, or the buildup of cholesterol in the walls of the arteries feeding the heart, and high blood pressure. Atherosclerosis produces CHF in 3 ways. The first is from a heart attack, which can suddenly reduce the amount of heart muscle available to pump blood to the various parts of the body. Second, CHF can also be a delayed complication of a heart attack. Whenever a heart attack occurs, a certain portion of the heart muscle is damaged permanently and lost forever. Unfortunately, the remaining part of the heart muscle must do the work of the entire heart. Hence, there is increased stress after a heart attack on the remaining working heart muscles. This increase in stress over several years leads to heart muscle weakness and CHF. The third way in which artery blockage leads to CHF is when the heart muscle receives enough blood and oxygen from partially blocked arteries to keep it alive, but not enough blood and oxygen for the heart muscle to work and pump blood. This type of heart failure improves rather dramatically when the blood flow is restored to the heart through bypass surgery or balloon therapy. High blood pressure is another important cause of CHF. If a person has high blood pressure, the work of the heart is high compared with when the blood pressure is normal. The excess work on the heart muscle can cause it to wear out after many years, producing CHF. High blood pressure can be compared to driving your car with the brakes on. If you drove your car with the brakes on, your car would wear out ahead of schedule compared to a car driven normally. This is why it is particularly important to treat high blood pressure and to lower the top number below 130 to 140. Another major cause of CHF are bad heart valves, which can be improved by medications and occasionally artificial heart valve replacement surgery. Alcohol is another important cause of CHF. Alcohol has a direct weakening effect on all muscles. It not only weakens the muscles of the body, it also weakens the heart muscles. Haven't you ever seen a team that was supposed to win an athletic event but lost badly to a lesser team? Very commonly, the game was not lost on the field, but in the bar the night before. Alcohol should be totally avoided in any patient with CHF. Any form of tobacco smoke, even chewing tobacco, are major causes of CHF and should also be avoided. Diabetes is another important cause of CHF, and for this reason, diabetes should be treated aggressively with tight control of blood sugar levels. Having low or high thyroid levels weakens the heart muscle and can lead to CHF. Being overweight also accelerates the risk of having CHF. 3 additional causes of CHF are iron storage disease, anemia or low blood, and thiamine deficiency. Thiamine deficiency is usually only seen in alcoholics who virtually never eat vegetables and whole grain cereals. In the past, the death rate from CHF was high since we didn't fully understand it, nor did we have an effective treatment. The outlook now, however, is much better. There are 4 classes of congestive heart failure. Class 1 CHF is when a person has a weak heart but feels completely normal. Class 2 CHF is when a person has slight limitations but really only develops problems with ordinary activity or strenuous activity. Class 3 CHF is when a person has marked limitations and has problems with minimal activity. Class 4 CHF is when a patient has problems from CHF at rest, such as shortness of breath while lying flat. If a person has Class 1 or 2 CHF, the death rate at 4 years is only 20%. If a person has Class 2 to 3 CHF, then the death rate at 4 years is 40%. If a person has Class 4 symptoms, that is, has shortness of breath at rest, then the death rate is as high as 65% within 1 year. Hence, whenever a person has problems from CHF, we see the person frequently to get control of the CHF and reduce the risk of death. The single most important predictor for survival in patients with congestive heart failure is the ejection fraction. The higher the ejection fraction, the lower the risk of death. The 3-year survival with an ejection fraction of 70% is 90%. If a person has an ejection fraction, however, of only 14%, the likelihood of surviving 3 years is on the order of 20%. Most of our therapy that improves the length and quality of life in patients with CHF improves the ejection fraction. Potassium and magnesium levels can also help us predict the risk of death in CHF. If the potassium and magnesium levels in a person with heart failure gets out of the normal range, there is a 4-fold increase in the risk of dying. Fortunately, when the potassium and magnesium levels are returned to normal levels, the risk of dying will drop dramatically. This is why blood tests for these 2 minerals are performed routinely to make certain that they are in normal limits. The typical evaluation for a patient with CHF focuses on 2 major issues. First, try to see if there is a fixable cause of CHF, such as high blood pressure, blocked arteries, diabetes, and the like. If fixable causes are found, then every attempt should be made to reverse the problem. Second, we also want to determine if the CHF is from weak heart muscles, stiff heart muscles, or both, since the medicines we use for the different types of heart failure are often very different. The routine blood work that we perform are iron studies to see if the person has the rare iron storage disease, thyroid levels to see if the person has a thyroid problem, glucose levels to see if diabetes is present, a complete blood count to make sure that anemia is not a problem, cholesterol levels since these contribute in a major way to artery blockage and heart attacks. We also check the sodium, potassium, and magnesium to be certain they are within normal limits. And finally, we check kidney and liver tests since many of the medications used to treat CHF can influence the kidneys and liver. There are several clinically indicated tests in the evaluation of CHF. The most important of these is the echocardiogram. The echocardiogram allows us to assess the size of the heart, the ejection fraction, the stiffness of the heart muscle, and whether or not bad heart valves are present. In addition, the echo image can also determine pressures within the heart itself and assess whether or not there have been any previous heart attacks. Exercise treadmill tests are generally performed in patients when there is a history of chest pains or a strong reason to suspect that blocked arteries to the heart are responsible for the CHF. In patients who have an abnormal treadmill test, cardiac catheterization is sometimes performed to determine whether or not bypass surgery or the balloon therapy is indicated to improve muscle strength. There are basically two therapies for CHF. That is, specific therapy for the fixable causes of CHF, and then there is generic therapy, which will help all patients with CHF, no matter what the cause. The best therapy for blocked arteries is a proper diet, cholesterol-lowering medications, exercise, total avoidance of tobacco in any form, and weight control. Occasionally, bypass surgery or balloon therapy is indicated. For those with diabetes, controlling the blood sugar to optimal levels is important. If a person has bad valves in the heart, then valve replacement surgery may reverse the CHF. Sometimes medicines can help improve valves that leak. Controlling high blood pressure is a cornerstone for CHF from hypertension. The major treatments for high blood pressure are salt restriction, low-level aerobic exercise, low-fat and low-sugar diets, weight loss, totally avoiding alcohol, and for those who need it, blood pressure medications. Other important therapies for CHF are correction of any thyroid abnormality, correction of any iron storage problem, correction of anemia, and for those who are thiamine deficient, thiamine replacement. Again, alcohol should be totally avoided in any patient with CHF. Salt restriction is extremely important to help control blood pressure, and restricting salt is also helpful in CHF patients. There are three key ways to restrict salt. First, avoid processed foods which contain high amounts of salt. In particular, canned foods, especially soups, frozen foods, pickles, and many of the common spices such as soy sauce and teriyaki sauce are extremely high in salt. Second, avoid restaurant food since it is also very high in salt. Third, do not add salt to food. The maximum amount of sodium that a patient with CHF should eat per day is 1,000 milligrams. One McDonald's has 1,100 milligrams of sodium. That is over 2,000 milligrams of salt. So you can see how important it is to avoid restaurant food, to avoid salty foods, and to avoid adding salt to food that is already prepared. The best way to ruin a vacation is to eat in restaurants all the time, load up on sugar, fat, and salt, which will lead to CHF and a trip to the hospital. One of the most important aspects of preventive therapy for CHF patients is checking your weight every day. The first sign of worsening CHF is weight gain. This will occur well before any shortness of breath or weakness. If a person gains 5 pounds compared to their normal morning weight, then it is extremely likely that this weight gain is from the accumulation of salt and water. Unless corrected quickly, this will lead to increased thirst, increased salt and water retention, and worsening CHF with shortness of breath. I once had a patient named Vernon who had Class 1 CHF and felt normal. He checked his weight every day. He went on vacation for 4 days and came back 4 days later and noticed that his weight had increased 8 pounds. He assumed that his scale was off. The next day he was 3 pounds heavier, and he really thought his scale was off. So he checked another scale with the same results. The next day he was 3 pounds heavier still and feeling normal. He decided to buy a new scale the next day, but that evening he awoke from sleep very short of breath and realized he was in CHF. He went to the hospital and was admitted. The bottom line, weigh yourself every day, and if you gain weight, don't think your scale is off. You're going into CHF. Let's now turn our attention to types of therapy which will help CHF no matter what the cause may be. As far as drug therapy, there are 7 major medications used in the treatment of CHF. They are diuretics or water pills, ACE inhibitors, nitrates, digoxin, beta blockers, calcium channel blockers, and blood thinners. The medical therapy for CHF is designed to increase the ejection fraction and reduce heart muscle stretch. These will in general prolong life. In addition, medical therapy is designed to increase the amount of blood pumped out of the heart, which will improve the quality of life by enabling a person to do more physical work. Finally, the therapy is aimed at reducing pressures within the heart and lungs, which will reduce shortness of breath. One of the simplest things that can improve ejection fraction and improve the amount of blood pumped out of the heart is to lower the systolic blood pressure. This is the relationship between the ejection fraction and the systolic blood pressure in any individual. If you increase the systolic blood pressure, the work of the heart goes up and the ejection fraction will naturally go down. By just reducing systolic blood pressure, you can improve ejection fraction and increase the amount of blood pumped out of the heart. The best medications to do this are the ACE inhibitors. ACE inhibitors lower blood pressure not only in the body, but they also lower the pressures in the lungs. This reduces the work of the heart and makes it easier to breathe. They also increase the amount of blood pumped by the heart, which increases exercise capacity. ACE inhibitors also prevent fluid retention and preserves potassium and magnesium levels. The most important thing about ACE inhibitors is that they have been proven to prolong life. The first study which demonstrated that ACE inhibitors increase lifespan in CHF patients was the famous Consensus study. In this study, the medical researchers took 253 patients with severe CHF. Half were given enalapril, also known as Vasotec, up to 20 milligrams twice a day, and the other half were given a placebo. The patients were followed for 1 year. Vasotec was initially started in very low dosages, such as 2.5 milligrams per day, and gradually increased up to 20 milligrams twice a day as tolerated by the patients. This shows you the tremendous difference in mortality between these two groups of patients. As you see, by the end of 1 year, patients who were placed on Vasotec had almost a 40% reduction in deaths compared to those who received the placebo. Hence, it is currently recommended that every patient with CHF from a weak heart muscle be placed on an ACE inhibitor if at all possible. The SAVE study also showed that ACE inhibitors increased survival in patients who had a recent heart attack. The medical researchers in the SAVE study took 2,231 patients who survived a heart attack and had weak heart muscles. Half received a placebo, and the other half received the ACE inhibitor captopril, gradually increased from 6.25 milligrams 3 times per day up to 50 milligrams 3 times per day as tolerated. Here you see the difference between the death rates in the two groups of patients with time. And as you can see, by the end of the study, there was almost a 25% reduction in the deaths in the patients who received captopril compared to those who received the placebo. As a result of this study, it is currently recommended that any patient who has had a heart attack and who also has a weak heart muscle with an ejection fraction less than 40% be started on ACE inhibitors even if they feel normal to prevent deaths and CHF. DIGOXIN is a medication which has been used for more than 300 years in the therapy of patients with CHF. This medication increases the strength of the heart. It also prevents rapid heart rates when used in the proper dose. DIGOXIN improves exercise capacity in patients with weak heart muscles. In a large study from the National Institutes of Health, DIGOXIN did not improve survival. However, it significantly reduced hospitalizations for CHF and improved quality of life. Unfortunately, high doses of DIGOXIN are clearly harmful, and DIGOXIN levels must be monitored at regular intervals in patients with CHF. Calcium channel blockers are a group of medications which prevent spasms in the arteries feeding the heart. They also lower blood pressure and certain calcium channel blockers will also slow the heart rate. Unfortunately, almost all of the calcium channel blockers weaken the heart muscle directly, and they have also been shown in 3 studies to either decrease survival in patients with CHF from weak heart muscles or cause worsening heart failure. If patients have CHF from weak heart muscles, calcium channel blockers such as diltiazem, nifedipine, and verapamil should be avoided, since each of these have been shown to have an adverse effect in those with CHF. A new calcium channel blocker called amlodipine or Norvasc does not appear to worsen CHF. In fact, in the PRAISE study, amlodipine was shown to improve survival in patients with CHF. Hence, if calcium channel blockers are necessary for angina control in patients with CHF from weak heart muscles, amlodipine or Norvasc should be considered. Diuretics or water pills are an important group of medications used to treat patients with CHF. They physically force the kidney to get rid of salt and water. This lowers the pressure in the heart and lungs, which improves blood oxygenation and increases heart muscle strength in patients whose hearts have been stretched excessively. Through these effects, the diuretics or water pills improve shortness of breath and quality of life in patients who have CHF. Unfortunately, the side effects of many diuretics is increased potassium and magnesium loss in the urine. So whenever diuretics or water pills are used, potassium and magnesium levels must be followed carefully and corrected if necessary. Another class of medications in the therapy of CHF are called beta blockers. These medications are a unique group of drugs and are now being used more frequently in the therapy of CHF patients. Beta blockers lower heart rate and blood pressure, but unfortunately they also decrease the force of heart muscle squeezing. For many years it was thought that these medications should be strictly avoided in patients who have CHF. Beta blockers, however, counteract the toxic effects of adrenaline on the heart muscle itself. Very frequently, patients with CHF have high adrenaline levels which damage the heart muscle directly. Several years ago, a very important Swedish physician performed some pioneering work which showed that when the beta blockers are started at very low doses and gradually increased, heart muscle strength improves along with survival in patients with CHF. Furthermore, the improvement in ejection fraction from beta blockers improves quality of life in patients with CHF. This study shows the effect of the beta blocker lopressor or metoprolol in a group of 226 patients with CHF. Half of the patients received the placebo and the other half received metoprolol initially, started at 3 milligrams twice a day, and gradually increased over several weeks to 50 milligrams twice a day. You can see by the end of this study there is a 26% reduction in all-cause mortality in the patients who received metoprolol compared with the patients who received the placebo. Perhaps the most exciting recent development in the therapy for CHF from weak heart muscles has been the new medication called carvedilol. This is a unique medication which is not only a beta blocker, but it also has the ability to dilate arteries in much the same way as the ACE inhibitors. In addition, carvedilol has antioxidant properties. That is, it prevents the heart and blood vessels from being damaged by the body's normal breakdown products. In summary, CHF is a very common medical problem in our country, but the prognosis and therapy has improved dramatically within the last 6 years. With the combination of ACE inhibitors, beta blockers, and diuretics, the death rate from congestive heart failure has roughly been reduced by a factor of 4 within the last few years. In addition, the quality of life has improved dramatically as reflected by reduced hospitalizations and improved exercise capacity in the patients who are on proper therapy. It is extremely important, however, to separate out weak heart muscles and stiff heart muscles as causes of CHF. Hence, every patient who has heart failure clearly needs an echocardiogram. In addition, fixable causes of CHF should be looked for so that proper therapy can be given. Patients with CHF should avoid sodium or salt, stay away from alcohol and tobacco, weigh oneself daily, eat a proper diet which is low in fat, sugar, and cholesterol, perform low-level aerobic exercise, and be certain to see a physician very frequently at regular intervals to monitor therapy. In addition, patients with CHF from weak heart muscles should avoid most calcium channel blockers with the exception of Norvasc or amlodipine. In addition, potassium and magnesium levels must be monitored regularly and always kept within normal limits. Patients who have atrial fibrillation or patients who have outpouchings or aneurysms within the heart should be placed on long-term blood thinning with Coumadin. Many patients with CHF have weak heart muscles and a reduced quality of life compared to normal. Frequently, CHF patients blame the heart failure medications for feeling poorly, and hence many people with CHF will not take all of their medications regularly. We have, however, clear evidence from all scientific research that taking these medications will improve the length and quality of life when taken regularly under a physician's care and with close monitoring. We encourage you to live properly and to take your medications as prescribed. You also need to visit the office regularly so we can closely monitor your progress in therapy. As you do, you will feel better, and live longer. I hope this program has helped you understand CHF and what we can do together to help improve the quality of your life and the length of your life.